This episode of GT the Podcast is supported by Alcon.
This is Ike Ahmed,
And I'm Arsham Shaybani.
and we want to welcome you to GT the Podcast
We're bringing this to you together with BMC and Glaucoma Today,
to offer audible insights into current topics in glaucoma care.
presented by the authors of our latest, most read GT articles.
Check it out.
Welcome to another episode of Survey Says with Dr. Paul Singh, a special edition of GT the Podcast, in which Dr. Singh presents a real patient case from his practice and asks his guests to weigh in on how they would manage it. Today's episode features Drs. Zarmeena Vandal and Joseph Panarelli. The guests share their perspectives on how glaucoma care has evolved in recent decades and how these changes have affected their decision-making process. With the glaucoma toolbox bigger than ever, they are intervening earlier and opting for surgery sooner. In addition, the wide array of treatment options has introduced new challenges. They discuss how they keep their surgical skills sharp and how to ensure trainees are prepared with a well-rounded education. Later, the panel reviews a case of a patient with primary open-angle glaucoma and a history of SLT and cataract surgery with the eye stent inject in both eyes. IOP in the right eye is in the mid-teens on no medication, but IOP in the left eye is in the low 20s on medication. The patient does not want to add more drops, and visual field loss has progressed slowly over the past 2 years in the left eye. The group shares which treatment option they would choose next for the patient, and later they find out how their colleagues would approach the case based on results of a poll of GT's audience conducted on social media. Tune in to Survey Says with Dr. Paul Singh.
All right, everybody, welcome to another episode of GT the Podcast Survey Says. My name is Paul Singh. I'm a glaucoma dude out in southeastern Wisconsin, and I have two really fun, great friends who are going to help me out with this case that we had you all kind of give your thoughts and feedback on in social media. But we have Zarmeena Vandal out in Austin, Texas. What's up, Zarmeena?
Hey, Paul. Glad to be here.
Thanks for hanging out after a busy clinic day. And then we got Joe Panarelli out in New York. Thanks for hanging out, you guys. You know, this is so much fun. I mean, I always joke around how lucky we are in glaucoma to have all these great options at our disposal to like treat our patients now. And you know, this whole idea is that, you know, what MIGS do you do, or drug delivery, or SLT, or, you know, subcon surgery, and the kind of the when, the why, the where is a question that still comes up. And I think it's still a good discussion to have because everyone has a different perspective on kind of how we use all these different technologies. So before I get into the case that we're going to talk about, and we had, of course, everyone out there give their opinions, I just want to get your thoughts. I mean, Zarmeena, why don't you just give us your thoughts? I mean, you do, right, drug delivery, SLT, MIGS, and subcon
Yeah.
surgery, right? So just kind of,
Absolutely.
yeah. So tell me about, like, I mean, has it changed, or just your thought process of kind of when you decide to do surgeries now, or intervene? Are you intervening much earlier, or doing procedures more earlier? What do you think?
Absolutely. I mean, I can't even believe the way we used to practice glaucoma, right? Compared to the way it is now. I would say 18 years later. I mean, when I was walking as a fellow at Mass Eye and Ear 18 years ago, I don't think I would have ever dreamed that we had this many options. And so much of our relationship with our glaucoma patients was really kind of talking them through their disease progression, because we were limited. And a lot of that limit was based on risk to benefit ratio. And we didn't have a lot in our toolbox. And for me, the most exciting part about being a private practice glaucoma person who is also at the intersection of practicing cataract surgery, of taking care of dry eye and all of these other things, is that our toolbox for glaucoma is bigger than it's ever been. And so for us, specific to the way we practice here in Austin, Texas, I can say early intervention is the name of the game. And when we are reaching for surgery, and even if it's just laser in the office to minimally invasive to incisional, is way sooner than it used to be, I would say, when I was a fellow, much sooner.
Yeah, and that's a really good point because you're in private practice and I am too. You know, we both do studies, and I mean, we both see kind of extremes from mild glaucoma or ocular hypertensive all the way to kind of the really scary kind of glaucoma that are progressing rapidly. Joe, I know you're out in New York, and you're kind of more of a tertiary care academic setting. So talk about your kind of experience with all these different devices. I mean, are you skewed more to the subcon just because of the type of patient population you see, or how does it work for you, and how you use all these technologies?
Yeah, I think, it's always a great question. And the honest answer is I have no freaking idea. There's so much out there. It's wonderful to have, but there's a ton of options. And really, I'd love to say that all of us have practices where we have, you know, a little bit of this, a little bit of that, and we can use all these tools. But like you're alluding to, it isn't the case in a lot of our practices. Mine is a little more skewed towards the more advanced patient population. So yeah, I am still sticking to subconj, micro shunting procedures, some traditional glaucoma surgeries. But listen, I'm not against, doing canal-based stuff when I have the right case. But I agree with everything that's been said. It's all about starting to intervene earlier, because I think we're diagnosing the disease earlier with really good imaging, and patients are living longer. So we are treating this disease for a very long time, and we need all the tools we can get.
Yeah, now that we've had, let's say, stenting for like 10 years now, and some other procedures even for like 8 to 10 plus years, do you feel like, so I mean, in private practice, do you feel like you're doing less traditional incisional surgeries because you have other options, or because we're treating earlier, we're not seeing as much progression? What do you think?
It's both. I do trabeculectomies and tubes so infrequently now, but I think it's a function of both. We go out into our community and educate our referral sources really regarding MIGS to the point where they send them in sooner. And because we have so many options. And so just the way that he pointed out earlier, I love the idea of being able to customize to the patient. If it's somebody who's advanced, as in his practice, it's going to be different. If it's somebody who's, borderline glaucoma, it's going to be different. But because there are so many options that are, I also think, um, you know, less scary for the patient and less scary for every single surgeon, whether it's comprehensive or glaucoma, because those procedures are a little bit more digestible, that the doctors are reaching for them sooner for that reason, and more apt to talk about them with the patient with a little bit more confidence. When you're talking to somebody about doing an iStent or a Hydrus, your conversation is going to feel completely different than if you've got to tell them, sorry, I'm going to do a trabeculectomy to your eye, right? And so I think doctors have also started employing these procedures sooner because of that, because of the safety profile.
Yeah, no, it's a really good point. And yeah, I mean, I think in my opinion, my practice, I think you're right. I mean, I do a lot less traditional glaucoma surgery, although it comes in waves. I have these days where I have like, tubes, and neovascular, secondary glaucomas. Like, oh man, they've already had previous trabs or Zens or whatever else. So it comes in waves, but I do see less. I think part of it's because we are treating earlier with other procedures and other diagnostics that are picking up earlier disease. And then yes, probably because I do probably do like a subconj MIBS, like a Zen before I do a trab couple times, so I'll incorporate like the MIB stuff beforehand.
Paul, can I steal your job and ask a question? Because this just came to my mind.
Yeah, man. Yeah,
All
dude,
right,
please.
I'm gonna play host here. It's interesting. I've been teaching for quite a while, and always in an academic setting. And listen, it's harder and harder to teach all these types of surgical procedures, and it's even harder for us to keep our skills sharp when we're doing such a wide array of surgeries. You know, we know that we're using these procedures earlier, but we also know they have a finite amount of time that they're probably going to be effective. You know, are we going to lose our skills in some of the bigger procedures? Are trainees getting enough? Like, I don't know. I was just thinking about that, because patients are living longer. That it's not, and we're treating earlier and we're treating more aggressively. But there's a lifespan on a lot of these mixed procedures. So are we just going to see a wave in the next few years where we're going to have to get more aggressive? I don't know. I just feel like that just hit me.
That's no, it's so funny because that was the question I was going to ask you. As a teaching institution, having fellows and residents, I was going to be like, you tell me what. So I'll take that answer, but I want to have you answer it too, because that was actually the
Yeah,
question
so
I was going to ask
I
you.
would
So
say,
you took my
as a
thunder, bro.
as a teacher, I've never worked so hard in my life. Like, trying to make sure that my trainees are really well rounded. I have to be very cognizant, of how many trabs, how many tubes, how many I'm handing over, what we're doing together. So I think the teaching has become, you have to be very uh, you have to be very aware of how your trainees are doing. And I think for me, I'm always trying to get them out there so that they have at least some fallback, some basic tools, and they're gonna have to keep learning on the job. I think that's the key. We all learned on the job, and you got to keep doing it.
So you said exactly what I was going to say. I think that's exactly right. You have to teach a skill set. So I think, a subcon, look, as much as I want to say I don't ever want to do a trab or tube again, guess what? I will have to do them again and again, and it's going to happen. And I think you're absolutely right. We cannot give up on traditional glaucoma surgery. As much as I love all the different options we have in the conventional outflow pathway and even lasers, I really would say that you needed to still learn how to do a trab. I think it's important for our residents, especially fellows, to have good experience with trabs and tubes, because you'll still need them and they're still great procedures. And a good trab surgeon has amazing outcomes. And so we don't want to minimize that. I guess to answer your question about do I think that we're going to have an influx of all these people who had like conventional MIGS and like 10 years later, boom, they're all come back?
Correct.
I think two
Exactly.
things. I think we don't have the data yet, but I will say this. I think when you treat earlier, and if you look at the data like the Horizon trial, 5-year data, et cetera, I think treating earlier in general, when you have a conventional pathway where the TM is not fibrosed, where the conventional outflow pathway is not completely fibrosed, with a decrease in flow, with fibrosis because of BAK, of the TM, and of the canal, like the distal channels, I do think I am seeing patients who are progressing less rapidly. It doesn't mean that you're going to have all of a sudden an influx of people who all of a sudden fail out of nowhere. There's still going to be people who progress like we would anyways, right? So if whether you do a MIGS, let's say a MIGS, conventional MIGS procedure, or SLT or drug delivery, you're still following them, right? But the progression is slower. So I don't think you're going to have a sudden one day they're going to come in, all of a sudden everything's failed all of a sudden, because we're still following them. And if they do, let's say, start to rise or pressure starts to rise, you put them back on drops if you need to. And then if that happens and they're still having progression, we'll still do trabs and tubes if we need to as well. So I don't personally think we're going to have a sudden like, oh my God, everyone's failing. But I do think that we'll be able to push the can down the road a lot longer. And then for some people, enough where they are still able to maintain good, quality of life and vision without having to do a trab or two because of the age. But there's some people who probably still need that as well. That's just my personal thought, and kind of data with all the Horizon trial and everything else that's come out, slowing the progression compared to cataract surgery alone with drops. I do think that we're going to see less amount, but still people who need to do trab and tubes. So, Amina, what do you think of that
You
question?
kind of read my mind there, Paul. I mean, the one point I was going to make was that when we throw MIGS in early, we're not just reaching them early, I think we're changing their trajectory. You know what I mean? So the way their glaucoma is going to behave changes because we got to their TM sooner. So I totally agree with you there. But I agree with Joe 100% too, that the role of the glaucoma subspecialist and needing to know all of the styles of surgery will never go away. But what MIGS does is it opens the care of glaucoma to way more than beyond glaucoma specialists, right? And there's so many doctors out there who really do need to be able to handle glaucoma. And if they're not adept at things like MIGS, then every time there's a cataract surgery that happens in a glaucoma person, then opportunity is missed. So I think of it as more additive and not necessarily taking away from a skill set, because those of us that are going to be fellowship trained glaucoma specialists are still always going to really be there, but we won't be the rate limiting step if MIGS is employed early. And so I think of it as additive, really.
Yeah, I think the big key you both address is that changing that trajectory, and that's what we're hoping. And listen, are we going to likely overtreat a good number of people that may have been okay? Sure, but it's all about trying to. I think it's all about trying to assess risk as best we can, and trying to alter that that path for a patient who otherwise would have gone on to functional blindness in their lifetime.
Yeah. No, these are really good questions and good points you made. And I think that's what we have to wait and see. Time will tell. Great, glaucoma is a long-term progressive disease. But I do think, and again, to one last point about the whole trajectory thing. I mean, you think about it, right? I mean, you do open a TM early on. This theoretically, you open that TM, whether it's SLT, whether it's MIGS, et cetera, you're going to keep that canal, but theoretically, patent longer, right? That canal stays patent. The episcleral venous system, the collector channels don't collapse potentially, right? The osseous don't close up potentially, and so that then changes the longevity of their outflow system working. So that's just I drank the Kool-Aid a long time ago. I'm still drinking it, I guess, but it is what it is.
You
But
do.
but but Zarmini, you
Oh,
made a good point.
you're pouring that Kool-Aid. You have like a whole refrigerator full of Kool-Aid.
Oh yeah,
Okay.
dude, that cool. I got
Mix
flavors
that
of Kool-Aid,
Kool-Aid.
all the Kool-Aid you
Yeah,
want,
keep
man.
it
Just come to my house,
together.
man. Come to my office. I got them all. But it's a really good point, man. We got to be fair and balanced about it, and we do have to teach our residents and fellows the full skill set. So that's a really good point, Joe. I'm glad you brought that up. But I do want to transition a little bit over to the case at hand, and because Zarmina made a good point earlier, just said, hey, if you have a cataract, you have a glaucoma patient on drops, and you don't do a MIGS or some type of glaucoma procedure, it is kind of an opportunity that you look back like, oh, that would have been nice to have done something at that time. But we look at the kind of quote unquote standalone MIGS world, right? The patients, let's say, have already had a cataract surgery, have already had something done, let's say an SLT. Now what, right? Do you do something? So, in the standalone market is still slow to I think, advance or progress. It's been kind of steady state, so to speak. And I think part of that's because, and I'd love to hear your thoughts, guys. Zarmina, you're in private practice. Joe, I know you have more tertiary, but you have a patient who, let's say, had SLT in general, and let's say has on drops and not happy, pseudophakic. Are you pretty happy and comfortable going in to do surgery just for that kind of patient? From, let's say, a MIGS?
For standalone,
Yep.
100% comfortable, and really educating even our junior surgeons and our referral sources to think early intervention for quite a while now. And again, it just boils down to, you know, how much opportunity we might have in the early stage of the game to revitalize their entire, episcleral venous network before it's too late. And so that's really our thought process and why we really try to get there. The other is the reality of all the chronic issues related to topical drug therapy. I mean, that's a real thing for us in Texas and in Austin, and so we tend to shy away from chronic topical drop therapy as much as possible.
It's a really great question. I 100% agree. Standalone MIGs definitely have a nice role. Um, my hesitation sometimes is driven by patient expectations. I will say this, that a lot of patients nowadays expect like perfection every time. They read about everything online. They do their homework, they do their research, and I'll say that getting that efficacy for a sustained period of time can be probably a little more variable when you're doing some canal-based surgery in patients who have had their cataracts already taken out, because we do know that the cataract surgery does provide a robust IOP reduction. But again, part of it is about your patient selection choice. But I think a little bit of it comes down to kind of, do I think I'm going to lose this patient if they fail? Patients often down the road shy away, and when they're like, oh, I've had 3 procedures, none of them really seem to work. Why am I going to go on and have something else? So just something to consider.
Yeah, well, I'm glad you brought that up, because that was my thought. I think that when I survey a lot of colleagues around the country, talk about standalone MIGS and why it hasn't grown quite as much, let's say, combo cataract, is to your point, Joe. I mean, when you go in there for cataract, if the pressures don't come down as much as you want, they're back on drops, patients are happy, they can see better. You're like, hey, I'm still a good surgeon, right? But, when you go in for standalone MIGS, and let's say you're trying to get them off a med or trying to get the pressures down, it doesn't happen. Do you feel as a surgeon, oh my God, I let my patient down? Are you afraid the patient's going to be mad at you? And, all those questions come up, and it's all natural. I mean, it's really important questions, and there's some variability depending on the type of procedure you do. And I think that's kind of where the rubber meets the road. And the way I deal with that, I'd love to hear you guys' thoughts on how you educate patients. We will get to the case, I promise, guys. But I want to hear how you educate and how you manage the expectations, because to me, it's about telling a patient it's a journey, and I'm going to institute and I'm going to utilize different technologies along this journey to maximize the quality of your life, but also address your glaucoma to protect you. But it may require multiple different procedures over the course of your lifespan, and kind of just managing the expectation that not any one product or drop or any one kind of technology is going to cure them, so to speak, but we'll try different things along the way. Do you guys want to comment on how you discuss surgery and going into surgery?
Yeah, absolutely. I'm gonna say for a second, I love the conversation you had about, our colleagues shy away from it because we're nervous about, are we really going to be able to deliver the result when it comes to minimally invasive. But I would challenge you to say, when it comes to the patient and, again, our colleagues in the community that refer in, their fear is the exact opposite, and that is the side effects and the long-term issues with incisional surgery. They're actually the exact opposite mindset. So we, as while we as glaucoma specialists worry about the results, they worry about complications. And many a colleague in the community have talked about how they're afraid of sending patients in for things like trabs, and you only need one, infected bleb with a blind patient to completely, change the mind of the referring provider. So I think when it comes to patients, actually, for minimally invasive, they're way easier to convince than we think they are, because to them, safety and efficacy in preserving vision and lack of complications is very compelling. And so when I have that conversation and I talk about minimally invasive as milder and having less of a chance of having something go wrong, the fact that I say, hey, it may not last as long in my patient population, they don't mind that as much when they hear that it's a lot safer. So that's the experience we have.
Yeah, no, it's a really good point. I mean, I totally agree with you. And I think I'd love to hear Joe's thoughts on this, but, do you talk about, hey, it may not work. And if it doesn't work, here's what we're going to do. I mean, do you talk about the negative of we have to do something more later on? Joe, how do you deal with that?
100%, because if you don't, I mean, listen, I tell them oftentimes the biggest risk with some of these procedures is it not working. And, you may be like, oh, it's not a complication, but, you know, it just lightens the mood a little bit. But I let them know, it's a possibility. I think the big thing is if you are getting referred from outside, making sure that your referring doc sets the expectations appropriately. I've had a bunch of patients come in and be like, I hear you can do this real simple procedure that's going to get me off all my meds. And I'm like, whoa, let's walk this back. Who said this? Do they want to do this? I think that's like one of the big things people have to recognize is that MIGS is not necessarily easy, but that's what it ends up, I think sometimes it gets dumbed down to in the community sometimes. It is, these are nuanced, getting these microstents or into the canal, catheters into the canal. It's a very challenging procedure to do it well and to really be in the right place. And that's what you need to do to get the efficacy that we would like to get. So now, Paul, I mean, I talk about it a lot of times. Patients know they've seen family members who have gone down, the road of, tubes and trabs and they don't love the idea of it for all the reasons that, Zarmeena talked about. Like there's a lot. I mean, listen, all you got to do is tell them to go home and Google a video of trabeculectomy or tube shunt, and they'll be like, yeah, that's not happening.
That's a good point. Well, no, I want to set the stage because now we're going to talk about the case. So thanks. That was a great pearls, guys. I appreciate that. So let's talk about the case. I'm going to read it out loud for everybody again, and then I'm going to have you guys comment on what you think you would do. So that's a 68-year-old. This is a real patient of mine. I'll tell you what I did. 68-year-old African-American male, history of mild POAG right eye. Left eye had moderate POAG and had a history of SLT in the past and had cataract surgery with an eye stent inject in both, in both eyes. Right eye did really well, off of meds, middle teens. Left eye, pressures are in the low 20s, but still on a PGA in that left eye. So the patient's basically like on one eye drops and not the other eye. Not happy about that because he doesn't want to take drops in general, had a history of having allergic reactions to drops and dry eyes and drops. And so he's like, I don't want to take drops anymore. And his field has progressed over the last few years in the left eye. So one eye has him drops on a PGA, already had SLT, already had cataract, and an eye stent in that eye. So the question I had posed to the world out there on social media, we did LinkedIn, we did Instagram and Twitter. We asked basically, what would you do next? So I'll read them out loud, then I'll have you guys kind of chime in. So the question was, we do SLT, another SLT, and or let's say drug delivery, whether together or separately. A goniotomy type procedure, GAT type of goniotomy type of procedure, some type of laser cyclodestructive, or some type of subconj, let's say MIBS like a Zen, or even a subconj surgery like a trab. So that was the options that I put out there as well. So before we get into the audience's kind of responses and the results, so I want to kind of get your thoughts. So, we have two different surgeons here. Joe's more of a subconj guy, but does some MIGS too. And Zarmeena does a lot of more conventional MIGS. So what would you do next? I mean, looking at those options in your situation.
This episode of GT the podcast is supported by Alcon.
Yeah, I mean, so the dry eye thing speaks big to me, right? And so I hesitate to do any sort of topical treatment in a person who I know long term that's just not really a viable option. One eye certainly doesn't have a PGA, so I do think of something like Durysta or drug delivery, anything to keep stuff off of the eye. But short of that, my tendency is again to go into the angle and deliver options for MIGS. And we're lucky enough in certainly our part of the country where canaloplasty hasn't been taken away from us yet. And so we are able to do the combo together and still offer it to patients as a viable option of canaloplasty plus goniotomy together. And so that's the thing, that's the type of procedure that comes to my mind. But I certainly feel that unroofing of the canal has to happen, in addition, and that's the direction that I would tend to go if MIGS is what the patient selected. And if not, and they wanted drug delivery, we could certainly go there first. And of course, in the ad, it doesn't have a PGA yet.
Okay, I'm gonna come back to that one. I'm gonna ask Joe his thoughts, and I'm gonna ask you some more questions before we get to the audience responses.
All
Joe, what would you
right.
do next, buddy? All right, here you go. I'm waiting.
Here we go.
I'm waiting.
Bring it on.
I'm waiting. Bring it.
You always, I got Steve Getty always in my head whenever I'm trying to make a decision. And, Steve's first question, again, I hate when people ask me a bazillion questions more about the case, but, you always want to know how the patient did with the initial treatments. Did they not work at all? Did they work for a period of time? And sometimes you don't have that information readily available. I think if you do, it does help guide your decision-making somewhat. The patient's age, bothers me a bit. The fact that it's already moderate, though moderate can span, quite a spectrum of disease here. I would lean towards a subconjunctival procedure if I'm trying to keep this patient off topical therapy forever. I think we have a good chance of doing that. And again, like you were saying, if you use it early, listen, we know with some of these newer microshunts, we get this patient may not need to be exceedingly low. This isn't a patient who needs a trab-like pressure of 8 to 12. Maybe a pressure 14 to 18 is okay in this patient. So I think you could consider a Zen, depending upon the patient's other risk factors. But, that's where I'm kind of starting.
Yeah, I mean, the beautiful thing about this case is that they all are good options, man. I mean, honestly, it's like there's no right or wrong. It depends on your comfort level. I mean, I think you're absolutely right. Where the target pressure would be is kind of that middle teens as well, 14, 15, 16 range. I'd be happy with even 17, keeping it more stable, getting him off the topical PGA. And the fact that he only is on just a PGA, not multiple meds, I think is a good sign too, that a lot of these different options would probably work. I'm going to give you my thoughts and kind of what I did and kind of what I would, Joe, what I would do. But before we do that, let's get the audience's review and their opinion. And then I want to get your thoughts on the audience's perspective. But yeah, man, those are really good points. We're going to talk about what you guys both mentioned in a second here as well. So the audience had a couple of things. So on Instagram, we had, it's actually really funny, Instagram, Twitter, and LinkedIn all pretty much followed the same type of, responses. Pretty impressive. So about 35 to 40% said SLT or drug delivery would they be their next option. Then 30% or so said goniotomy, kind of GAT. Very few, only like 3 or 4% said some cyclodestructive like ECP or like micropulse or something like that. And then about 20 or so percent said subcons like a Zen. So it was a pretty good spread. I mean, and I looked at LinkedIn, we looked at as well as Twitter. It's pretty much follows the same about same kind of percentages as well. So
it makes sense. None of the options are wrong. They're all good options.
Yeah. I love it. That's what's so great. So let's dive in more deeply. So I'm gonna kind of talk to. First of all, I'm gonna go with what Zarmina said, and then I'm gonna talk about what Joe, what you did. So Zarmina, I did kind of what you had suggested. I did really more of I did a GAT, canaloplasty GAT procedure. I went around those two stents.
Right.
And
that's why.
I'm sorry.
I said because that's the right choice.
Oh, dang, slam! Damn, she slammed that one. But here's why. Here's why though, because I think Joe's right, man. I think look, you could do a Zen in this patient would be great because even if it did, let's say, creeped up a little bit there, fibrosis, interstitial fibrosis, some T-nons. He's an African American guy. He might have some fibrosis. We need some needling. If his pressure goes up to 17, 18 range, but stays stable, he's off of drops, I'm happy with that. So Joe's right. This is a great patient for a Zen, actually. But the reason I said, okay, we always have the Zen in my back pocket. I can always do it. And I think it's a great option there. But what I did is, look, let me just go ahead and still one last time, maximize the conventional outflow pathway, do a canaloplasty GAT. That's it. We're done with the conventional pathway after this and see how that works. And then if that doesn't work, we can always do a Zen later on. What I ended up doing with this, guys, I did a GAT, and the pressure was not bad. It went up a little bit there, so I did a Durista after that to keep my drop. So I combined it a little bit there. Does he might need a Zen later on? Absolutely. I think he probably will eventually in that left eye for some reason, but we'll see. I mean, right now he's doing pretty well. Actually, it's been about, I think, 6 months after the Durista, and he's still doing pretty well. He's in like the middle teens right now, 14, 15.
Let me ask you out of curiosity, in your patient population, what is your rate of failure with Zen? Like, how many of them scar?
this patient may be, that's what I was alluding to before about risk factors. A younger African American patient may not be the best Zen candidate. I got to tell you, I know we may not want to hear this. I might consider, just tubing this patient, or even doing a trap. It's crazy as that sounds. But if I felt that this patient has, a real significant risk, maybe the patient had, a family history with a relative who went blind from glaucoma, that might sway me to get more aggressive early with more of the traditional surgeries, because these patients sometimes quickly will fall off on you. I mean, it's always hard knowing who are going to be those fast progressors. And so I think my Zen success, because I'm careful with my choice, probably is 70 to 80%, in terms of get my patients to where I want them to be, which is not progressing. And again, that's not an IOP necessarily, success, but getting them stable.
And I meant to ask that only because of exactly what you pointed out, which is that all this could be customized. And so what's good in one person's hands may not be in another. And so to give you our example, like in our particular community here, when we were doing Zens, like 40% of them were failing after a while. And so that's just that caveat. And then what I love about this case and all the options is that there are so many options. And for us to know that about our practice, you know what I mean? That if the Zens are just not doing well, then maybe that's why we do we're going to intermediary step of MIGS and then just go straight to filtration. So that's probably the reason we've tended to go that way.
Yeah, and I think you guys brought up a really good point. And Joe, I'm glad you brought that up about this. And it doesn't always mean much lower IOP. I mean, stability of IOP you look at ages on the data sets out there. I mean, fluctuating IOP independently can be a risk factor for progression in some people. So sometimes just we don't realize how much IOP fluctuation can be a risk factor. So you don't have to be super aggressive sometimes. Just keep it stable if you can. And that's a really good point. The other thing I was going to say is, I mean, when you look at these options, what option you do is it going to limit you from doing further future options? And the one benefit to me of the conventional outflow pathway, and you know what, a lot of people, it may not work, it may fail, you may have to do something else, right? Absolutely. But the good thing about that is that you say, okay, if it doesn't work, I have my Zen, I can do, not a problem. The subcon space is still there for me. And if the Zen doesn't work superior nasally, guess what? I can do a trab, or I can do a tube superior temporally if I have to. So you're always thinking about what's next if this doesn't work as well. And that's why I think when we talk about conventional outflow MIGS, when people kind of give it a bad rap for more moderate to severe patients, and absolutely a trab and tube is better for some people, no doubt. But those patients where you just want to get more stable, you always have that option later on. And as long as you tell the patient, look, this may or may not work. If it doesn't, you have that other option. And I tell them ahead of time. That's what I told this guy as well. And so I think that mentality of it's not this or we're done, it's this and then what's next if need be kind of mentality. I'm not sure if that's how you guys are feeling it, but that's kind of why I asked earlier how we manage the expectations. And that's kind of what I felt like for this guy. But any thoughts on that, Joe?
Yeah, I mean, it's always just a little bit tricky, right? I mean, we talk about, kicking the can down the road, and sometimes the patients will just be like, Doc, can we just finish this? I don't want to worry about this anymore. And it's a balance. I mean, that's part of the art of doctoring is, trying to, understand the patient that's sitting in front of you and figure it out. Yes, I think it makes total sense. If a patient said to me, Doc, I'm going to stick with you for everything and just do whatever you want, it would always make sense to go a stepwise approach and sort of escalate based upon, your risk assessment. But, it doesn't always work that way. And again, the second point I'll make is the rate of progression. It's hard. Sometimes you do a surgery on one of these patients and the pressure actually goes up because they have some bleeding or something else go on, and you awaken a sleeping giant. So, they have to understand that is a possibility, that you have to move on, a little more quickly than what you would have thought.
Yeah, and that's a really good point. I think what would have changed, I'm asking actually Zarmina, if this patient was on 4 meds or 3 meds and on the pressure 20s, would that change your mindset of what you would do next?
Absolutely. And that's a great segue into, the titration of what's needed for every patient. Everybody's glaucoma is the same. And so that's telling me right away that his glaucoma is way more resistant, right? Than if just being on 1 meds and in mid-teens. So I would definitely skip drug delivery in that case, but I still would at least try unroofing the canal goniotomy. But my quickness to progress to the next step would be a lot quicker and much lower thresholds. And then you throw in there, as Joe mentioned before, race or a very aggressive form of glaucoma. Maybe 5 people in the family have it, and so then maybe we're going to Zen right away. So yeah, every case should be customized. we didn't have the luxury of that in the past, and we do now. But we have to think about every case differently. But definitely, more medications would really push us in the more aggressive direction for sure.
Can I ask the two of you, my angle whizzes here? Um, does it make a difference how that first iStent or how the SLT performed? Does that make you more apt to do something or not to do something, or is it really it doesn't make a huge difference because of the the procedures that you're thinking about doing?
The purpose of unroofing the canal, I have to say that I tend not to. I will still give that a go. I know there are thoughts out there of how the angle responds to SLT and to what you can expect. For me, again, because I'm talking to this patient about, hey, we're treating this condition together for the rest of your life. I present them more with look at how many options we have. So it's exhaust one option at a time. So I hate to cross that off, just because of how they might have responded to SLT when it comes to unroofing. I still would go there.
Yeah, I mean, that's a good question, Joe. I mean, we have some data we kind of presented a while ago based upon like our stenting data and SLT, and that people who have historically a poor response to SLT tend to not do quite as well with, let's say, trabecular microbypass alone, like iStents. But it doesn't mean that tells you that it's not only the TM; it could be in the canal or the distal collector channels. So, as Armino was saying, if you're unroofing the canal and you're exposing to the episcleral venous system, there's a good chance that some of those people who didn't respond to, let's say, a stent or didn't respond to SLT rather may respond to this unroofing because it may have been the canal collapse and you're opening it up. So, but you're right. There's some people who still, even with that, the EVP, the episcleral venous system rather, might be messed up and they may not be able to respond regardless of what you do in the canal. And that is part of the crapshoot. We don't know where the resistance to outflow is preoperatively. So we are kind of guessing with conventional pathway versus with subcons, you kind of know it's all about the flap or your Zen and your subcons, your resistance of the interstitial resistance of a tenon. So
And I actually think I might even have another option here, Paul, for you. That I think might be available sooner rather than later. You were just doing it, weren't you?
Didos?
Yeah.
Yeah. So that's the question I was gonna. Yeah. Well, so that was the last question I had. Dude, you were like in my mind tonight, dude. There's something.
That's what I do. That's what I do.
Dude,
Underneath
you
the
were like
I'm right
in my
there.
mind. So yeah. So we talked about drug delivery. We had Durista, a great product as well. And I use everything, right? But recently we just got approval this week, last week, of the intracameral travoprost delivery system by Glaukos called the iDose. Now the question that they have data that supports, about a year out, about 80% of people are off of meds and still controlled, and about 3-year data, but well over 65% or 70% are still controlled with same or less meds at 3 years. So there's a little bit of longevity to that one. Still about 30% reduction of IOP. So the question is, would you do that along with, let's say, your conventional outflow MIGS? If we get reimbursed, well, that's another question that's going to happen. Or do we do that alone in some people and it's going to get that 30% reduction, potentially in a patient like who's responded well, let's say, to PGA. The problem with this guy is this guy he was already on a PGA and his pressure was 20s. That was the reason why I was like, you know what? I think I have to do something more than just like a drug delivery alone, just because of the fact that he was not responding as well as I wanted to and progressing on a topical PGA. If he was controlled on a PGA, meaning IOP was in the middle teens, but he's just like, I'm unhappy, eyes are dry or red, etc., then I think a drug delivery alone, like an iDose, would be a great option, honestly. That's kind of where I think where it differentiates this guy. But yeah, it's a great option, I think, especially alongside a conventional pathway MIGS. You're doing your GAT, you're doing your canaloplasty, whatever, your goniotomy, and you just put this thing in there at the same time, you're already in surgery, that it gives you that 30% reduction. You get that PGA in there for a few years. I think it's a great option. I mean, what do you think, Joe? Would you use that in your kind of population patients?
I gotta tell you, of all the things out there, this is the one for me, as maybe a guy who's not doing as much MIGS, I'm pretty excited about. I gotta tell you, I'm all in on medications inside the eye. I don't know if it's that they're gonna alter the outflow pathway permanently. I don't know, but I've had people on PGAs who maybe they were not at target because they weren't using the drops, which a lot of these patients who claim to have side effects don't use their drops quite as much. But I've seen it with Durista. I put some of them in patients and I'm like, whoa, it works. I mean, I've never worried about intracameral drug delivery working. We've all just been a little bit concerned about some of the safety profile issues that may have been seen in other trials, but I got to tell you, I'm excited about the iDose, and for me, I would like it. I kind of like it here.
I mean, just to address the compliance alone, right? And when you get this whopping amazing effect with the Durista, it's like that's telling you something about the patient maybe not even taking their PGA regularly, right? And so there's just so many wins with intracameral or just drug delivery in general. It's just taking, consistency out of the equation when it comes to the patient's compliance, and it's a big deal. And so, yeah, I think it's a big win, and I also love the additive nature of it and how you can kind of feel like you're doing more by putting two things together at once. So I think I think it's the way of the future, more and more so. Just a matter of the doctors getting comfortable with it.
Well, Joe, you brought up that comment you made just now. I'm not sure if you guys heard what he said. You have confidence that it's going to work, right? I mean, earlier we talked about why some docs aren't comfortable doing standalone MIGs. Well, is it going to work or not? There's some variability of efficacy based upon anatomy, physiology, procedure, technique, etc. Well, we all kind of feel comfortable. We know that PGAs work, and we know from the data.
I mean, that's it. So to me, this is like, for me, somebody who has at times been skeptical of some of the canal-based procedures, just because there's so many unanswered questions with the patient's outflow system. I don't know, guys. I'm never upset typically when I start a PGA, or PGAs they make me feel all warm inside.
We want Joe to feel warm. We want Joe to feel warm.
It's like a guarantee on a box. It's like a guarantee. Okay, you stamp that guarantee on there. I'm good.
Dude, I love it, man, and that is a really good thing. I think that's what's we're gonna see, and I really do think, and again, not sure how it's gonna work out with reimbursements, but I do think, I'll tell you this: all tides rise when you have more options for patients. So now we have Durysta and potentially iDose soon coming up, right? Already approved. I think you're going to see more doctors just saying, okay, now I'm going to get involved with the drug delivery world now, whether it's the iDose or Durysta, whatever, we'll see. But I think that's more noise, more people are realizing, okay, I have these options. Let me think about it now versus just kind of waiting around and waiting. So that's my big push, right? We have these options. Whatever one you decide, whatever you feel more comfortable doing, whatever's available to you, it doesn't have to be one or the other all the time. But I think just thinking about this idea that patients do progress, Joe, your point was well taken. And we don't know who's going to be a fast progressor, who's not. Risk factors, compliance, quality of life, all these different issues that we now are realizing more and more have an effect on their longevity and their stability of glaucoma over time. So, no, man, you guys, this was awesome. Any last comments from both of you about just this case or about kind of where we're headed in glaucoma in general? I'd love to hear your thoughts.
Yeah, I mean, when I think of the glaucoma revolution, these words that we throw out, so much now and get all giddy and excited about as glaucoma specialists, I think some of what we just talked about hits the nail on the head, right? Part of the revolution is about us as surgeons. And we just proved just in our 40 minutes that if there's one type of device or option that makes a doctor want to dip their toe where they before were skeptical, it's a win. And so for me, that might be, traditional MIGs. For Joe, that might be intracameral travoprost. But the point is, more patients will get more options, and that's really what I think this revolution is about: is to really fight glaucoma with as many options as possible that aren't just there for the patients, but are there for the clinicians also. And it's exciting.
No, absolutely. Joe, what were your thoughts, my friend? Any last comments to the audience?
Yeah, totally agree with everything that's been said. I think it's been a fun time. I think you've said it a lot. Customize it. Each patient's different. If something's better for the patient and you don't do it, get a colleague. I love it. I have great colleagues at NYU that I could just, send my patients on over to because I feel like it's more appropriate or better in their hands. So, we work as a team. We always just try to find the best option for each patient. And, it's humbling to do this every day.
Oh, man, I love it. You guys are awesome. This was a lot of fun. I'm not just saying that. I mean, I loved hearing these comments, man. You guys are awesome. Thank you for sharing your thoughts, your wisdom, just making it fun, and hopefully helping our colleagues out there with some pearls. I know we're all learning from each other consistently, and that to me is what keeps me going, is learning from everybody. And so everybody, stay safe, stay healthy, keep pushing forward, keep questioning each other, keep questioning yourself, see if we can keep doing better for ourselves and for our patients, more importantly. So thanks, everybody. Enjoy, hopefully, for another episode of this podcast someday soon. Take care, everyone.
Thank you for tuning into this episode of GT the Podcast. If you have any feedback or topic suggestions, find us on Instagram, LinkedIn, Facebook, or Twitter. And stay tuned for more hot topics in glaucoma care on GT the Podcast.